So hello, my name is Dr. Dwayne Cumberbatch, and today on Ames Health, we'll be discussing QUARANTINJURIES. Now, some of you may be wondering what the heck is a QUARANTINJURY. So basically, during this period of isolation and social distancing, people are trying to be more active, and with that increase in activity, people may be finding themselves with more aches and pains that they did not have previously. So today, I have the pleasure of discussing these issues with two of my close colleagues, Dr. Eugene Vitelli and Rick Landerman. Now, Dr. Vitelli is one of my partners. He's double board certified foot and ankle surgeon. He practices in Naples, Florida. He has a lot of experience treating high-level athletes, from Division I collegiate athletes to professional sports athletes. And most importantly, he had a cameo in Ballers. The first two seasons were great. I haven't watched season 3 past, but that's neither here nor there. So, and also here we have Rick Landerman. Rick is co-owner with his wife of Beyond Motion. Is that Naples or Bonita, Rick?
It's in Naples.
Naples, Florida. He has a BS in exercise science from Colorado State. Those are the Rams, right? Colorado State Rams?
Yes, sir.
Yes. And he mentored under the tutelage of Hall of Fame strength and conditioning coach Albert Meal with the Bulls. He was also with was it Bears too? Bulls and Bears?
Colorado Rockies.
Colorado Rockies, all right. And he also helped to assist me in recovering from my patellar tendon injury a few years ago, and I'm pleasure to have him here. He knows a lot. He's well versed in sports medicine, and we're going to discuss some of these issues right now. Okay. So first one we're going to discuss is plantar fasciitis. Now, Dr. Vitelli, let's see I want you to kind of give us the sort of the 30,000 feet, view of plantar fasciitis, how we diagnose it, how you treat it in your office and practice, both surgically and, non-surgically and surgically.
Very good. Thank you, Dr. Cumberbatch, for having me. Plantar fasciitis is definitely one of the most common conditions that we see, and not only in the athletes, it's in the general population as well. And what's it from? It's really an overuse type of injury. It's an inflammation of the plantar fascia or the band of tissue, the cord that helps support your arch. And it can be tight from a lot of reasons: stress, too much exercise, not enough stretching. Most common is really not enough stretching of the overall heel cord. Now, obviously, we can't stretch a plantar fascia. We can't stretch an Achilles tendon. But what we're looking to do is elongate those long muscle fibers in the calf. That relaxes the pull of the Achilles tendon and the fascia. Now, obviously, when you speak of plantar fasciitis, it's almost logical to talk about Achilles tendonitis as well, because they're very, very similar, and they usually present in the same type of patient. How do I diagnose this? A lot of this just comes by the history and physical, about telling me where the pain is, pain upon palpation of the actual fascial heel cord. Ultrasounds are real good to show the inflammation, also to rule out tears of the fascia. Usually in my higher end athlete, it's a little bit beyond the fasciitis, because they just work and let this go, where they usually do develop a tear. So that ultrasound is a real good tool to see what is actually going on. MRI is also very, very useful. Helps us out to determine the extent of the tear and the degree of the tear. Treatments are usually always the same. I'm not very big on cortisone shots. Patients in my practice ask me all the time. I'm not very big on them. I'll give them to you if you're in severe pain to make you comfortable, but I'm a big believer in let's do something in the healing realm. PRP, or platelet-rich plasma, stem cell type of therapy, all these adjunct injections to actually stimulate healing. There's a lot of great articles right now showing that PRP and shockwave therapy is actually more effective than cortisone shots and produces healing.
Great, great. Yeah, I like that's a great point. You know, usually I utilize the cortisone injections just a way that if patients come in with a severe pain, you know, anything over 7 out of 10, you know, try to give them some relief and then and kind of ease that while we figure out how we can best treat it. So Rick, from your standpoint, you know, when you're dealing with those athletes that have it and this kind of, especially this time of year, you know, off season, you know, they're trying to get back in the shape or get their programs going. How do you manage those patients that you or your clients that have this issue?
Well, I mean, I think, you know, Doc hit it right on. I think workload is a huge thing. So the first thing, if we see that issue come up, the first thing we'll do is probably send them to you guys to see if it's what we think it is. When it does come up, it's usually from overuse or underuse, and then obviously the usage actually it gets extended. Once that inflammation occurs, you know, PRP, all those healing mechanisms you have to go do because it pretty much sidelines the athlete. There's not much you can do because the pain is just so sharp and painful for them. And then the Achilles tendonitis sort of goes hand in hand with it, like you said. So our goal is to basically get the inflammation down as best we can. So we'll actually work on the soleus and the gastroc, which is in the calf, to make sure we can actually release that. And we'll do that through soft tissue aspects. But you know, quite honestly, once we get to that point, we really put them in your hands and say, hey, you know, this is what we think it is. You know, why don't you let us know? And then we let that healing process occur, and then we bring it back slowly. But with the younger population that we don't see a lot of plantar fasciitis. We see that with the older athletes, my 30-year-olds, my 34, 35-year-olds. And usually it's from just ramping up volume too quickly and intensity too quickly. So it's the guy who's a gamer on the couch in the off season, and then you take 3 weeks off after season, and then we slowly engage with some running or some other aspects, and it's a nagging injury that starts to occur a little bit, gets more prominent, inflammation becomes more and more, and then there all of a sudden is a tear. So we try to you know, obviously derail that as quick as possible once we see symptomology come up.
Right. So how about afterwards? What about you know, after they had their bout of plantar fascia and they're kind of trying to get back? What's your protocol in getting them back on the field or on the?
Well, first start with, you know, I'm big on ground contact, so I want to see what relationship the athlete has with the ground. And once you have plantar fasciitis or Achilles tendonitis, you actually, you know, you lose that ground contact, that relationship a little bit. So we'll start with a light skipping mechanism just to actually get that relationship back and get that rhythmic feel back. So we'll start them with almost like a dynamic warm-up, extended. And before we start any kind of too much, you know, pressure on that tissue, we'll just keep on doing that repetitively until we slowly bring it up to like a gauge 1, gauge 2. And the gauge 2 would be something similar like a light jog, seeing how they tolerate after that. And then once we get through the light jog, we'll slowly start some acceleration mechanics. But once again, you know, you guys see a lot more than we do. My pro guys, we really don't have those issues. I'll be honest with you, we don't.
That's great.
Yeah, I mean, you know, we have a lot of post ACLs. We got a lot of post meniscus, UCLs even with Tommy John. But foot, I mean, I don't know if you know, everyone knows about Beyond Motion, but we do a lot of Pilates here too. And if we can get that gastroc and that soleus to release, and like you said, release upon the tendon, then it's going to actually help the healing process and actually get it so it's not a symptomatic, you know, doesn't become an issue. So if we get the athlete in Pilates relatively quick in their inauguration and their orientation aspect, we don't come across too many issues like that.
All right, good. So Dr. Batelli, what do you think about the role of the gastroc in that plantar fascia? Do you do any gastroc recessions or anything like that with any of your patients?
Well, it's actually funny you should mention that, because traditionally, if you have plantar fasciitis, you had some type of heel spur type of surgery, whether it would be an open resection of the plantar fascia or a endoscopic release of the plantar fascia. But current data supports that that's not the right thing to do, because you're going to destabilize the foot. You're going to lose basically that support of the talar head and induce a flat foot, that the proper treatment or the proper surgical treatment for plantar fasciitis would be to release that gastrocsoleus complex. And we do that by actually lengthening at the aponeurosis. You're not weakening the Achilles tendon because you're not lengthening the Achilles tendon. All you're doing is freeing the aponeurosis from that gastrocsoleus complex. It allows it to slide on top of each other, lengthening that overall heel cord, and you don't disturb that fascia. Obviously, one of the main treatments that we do with plantar fasciitis and Achilles tendonitis is check the biomechanics and put them in some type of orthotic to control rear foot motion, to support that spring ligament. And by preserving the plantar fascia, it just goes one step further and allowing that athlete to return to function a lot quicker.
All right.
What percent, Dr. Patelli, do you see go into surgery that come to you basically besides doing a PRP or non-invasive mechanism?
Less than 1%.
Is it?
I think the shockwave therapy and the PRP has come so far that it's very, very rare that I have to operate on plantar fasciitis. In a high-end athlete, and I'm thinking, when do I get this the most? Combine season. The 6 weeks before the combine, you got these college kids that took a couple weeks off after their game, after their bowl game, and now they got to ramp it up again, and that's when they're getting the most. They rarely ever need surgery. A PRP shot, extracorporeal shockwave therapy, some type of mechanism to stimulate angiogenesis, to stimulate cytokine production.
Hey, don't geek out on me. Don't geek out on me too much, Dr. Patelli. Hold on, don't geek out on me too much.
Let me just ask one more question based on that. So when you PRP, and I was at a conference a few months ago actually at this point. The quality of the PRP was the question, and
Correct.
the spin ratio. Can you go into that for a second? Do you mind?
Unfortunately, there's no standard of PRP. You have some systems that are basically a 2-to-1 increase in cytokines and growth factors, and then you have systems that are as high as 64-to-1. Some people believe that the 64-to-1 is too acidic and is actually counterproductive. So we don't really. Unfortunately, there's no literature out there supporting which system is best. The only way to do this would be with a double-blind study. No one has been able to undertake this. Consensus is an 8-to-1 concentration or a 16-to-1 concentration seems to be the most effective in lowering the overall pain scale.
Okay.
Yeah, that's
makes
great.
sense.
Yeah, and my hands also. I rarely have to do plantar fascia, surgery. Recently I have done a few gastroc releases on some patients. They have good relief of discomfort. But most conservative treatments, and gradual increase in activity, modification of their activity. I think that does it. That's great in getting these people back to what they need to do. So now that we completed, with the plantar fasciitis, we can move a little bit up the chain to Achilles tendon. And Dr. Patelli, can you just break down a little bit of the Achilles tendon, difference between tendonitis and tendinosis and tendinopathy, some of those terms that may get thrown around a little bit?
Yeah, you're going to see a lot of these terms, especially on your MRIs. And I think the easiest way that I can explain is that a tendonitis would be an inflammation of the tendon. The Achilles tendon is basically almost like a braided cable. If you ever seen one of those cables which support a telephone pole, you see it's many. The one cable is spun from multiple smaller cables, and that's basically what the Achilles tendon does. So in your phase 1 or stage 1, which would be the tendonitis phase, it's just there's inflammation cells around there. When these inflammation cells hang around a long time, that causes a fatty change, a degradation of the tendon where fat gets in between these braided fibers. And as a result, that's when we see tendinosis. If tendinosis is left untreated, it will lead to longitudinal tears and ultimately failure of the Achilles tendon.
All right. Now, what do you like to do for from diagnosing, and then after we diagnose that condition, treatment? What's your treatment options?
My diagnosis is basically the same. I rely on ultrasound a lot to rule in and rule stuff out, and I think it's great for Achilles tendonitis. I rely on my MRI to really look in depth and see if there's any tendinosis in the fibers. And treatment, once again, would be correct the biomechanics via some type of orthotic. A lot of physical therapy with this. I mean, your physical therapist is your best friend with Achilles tendonitis. And if and extracorporeal shockwave therapy, which once again stimulates angiogenesis or little capillary production in the lining around the Achilles tendon. More blood flow, more food, you're going to get this to heal. I don't obviously do cortisone shots to Achilles tendons because the cortisone is counterproductive and can weaken it. But occasionally I will do a PRP injection to the area if the tendinosis is just not responding to biomechanic control and physical therapy. Me being a sports medicine specialist, I don't put people in casts. I don't put people in walkers because that's not, I don't have that luxury of putting someone in a cast for 6 weeks and telling the coach that they can't produce for you. Whether a college athlete getting paid literally hundreds of thousands of dollars now worth of scholarship money, or whether they're a pro athlete, I got to keep them active. And once again, that's where the control of the biomechanics with an orthotic and your physical therapist become your two major treatment plans.
All right.
So may I ask a question, Doc?
Sure.
Dr. Cumberbatch, I can tell you either or. What, when you see that and you talk biomechanics, what's the most common thing that you see relay to an Achilles tendinopathy or Achilles tendon issue, whichever it may be the common denominator? Does that make sense?
Oh no, absolutely. And I see mostly a flat foot and a incompetence of the spring ligament. And the spring ligament basically is a band of tissue which holds up that talar head. And once that talar head declines, it allows the foot causes the foot to pronate. Now you're having an abnormal pull of the Achilles tendon that leads to shortening, and you get this snowball effect.
Right, and it's fascinating because that same issue is when we have with our ACLs, non-contact ACLs. It's usually 9 out of 10 times if you look at the athlete's foot, it's flat foot, and the doctors don't talk about that at all or don't get orthotics for it at all until we discuss it. So.
Yeah, I mean, it's, from our standpoint, generally podiatry, we're a little more, we kind of lean a little more on the biomechanics a little bit more when it comes to these things. So that's where, we'll assess, whether it's orthotics or some sort of inserts or, the stretching, with the gastroc, with the equinus, helping us something to help limit the pronation is key. Pronation is a big cause of a lot of the issues that we see. I mean, biomechanically, we try to assess the patients, especially if they are going their route for surgery. And we don't like to do surgery. You like to exhaust everything conservatively before we go around surgically. So how about for you, Rick? Do you see? I mean, I know you say you don't see much of the fasciitis, but I'm sure you see some of the Achilles issues, or even talking about in regards to Achilles. What about that post Achilles rupture? Those clients that have just recovered from Achilles tendon rupture.
Oh man, I mean, to be honest, I've worked with Chicago Bulls, Rockies, and all over. I mean, I can count on one hand how many Achilles tendon ruptures we've had, and wow. It's not a common. You guys see it all day long. It's just not a common injury that occurs that we come across. I know it's ironic we talk about it because I think it's, for all of us who play basketball still, like myself, it's our biggest fear, right? We get a little
don't bring that up, man. I'm starting to sweat right now.
Well, I'm just saying, you get a little tender in there, and like I'll shut it down, like hold on a sec. I'll go to a little soleus stretch, I'll go to a little gastroc stretch, and then I'll slowly engage and a little more. But I guess more poignant would be the fact that before it occurs, we get more of it, and once we see some tendinopathy occur, some tenderness start to happen, is we'll teach the athlete, number one, what's the difference between the soleus, what's the difference between the gastroc? How do you stretch one? Can you bend the knee a little bit and get a little more soleus compared to gastroc? Then we do a lot of soft tissue therapy with it at the same time, so we can get some expansion of that tissue to make, we can release a little bit of the tension on the Achilles tendon. You know, Achilles tendon, I like to say, is almost like very similar to like a Tommy John aspect. Is you can't strengthen it per se, but you can regulate some of the muscles around it and strengthen it so there's less pressure on it throughout the movement pattern.
Right.
So we do our best in that category. Now, if I have a post Achilles tendon tear in a pro athlete, that's you know, knock on wood, I have not encountered that yet.
All right. Well, that's good. So I guess I'm gonna lead into another one. Is something I was kind of suffering from a little bit the last couple weeks was some shin splints. Now I was trying to run, you know, in this time that we had off. I was trying to do a little more running, which I hate. Despise running. I mean, Rick, you know how much I hate running. You could probably test it a little bit. But can you go a little bit into that a little bit first? I'll have you start off first with what shin splints are and how we can manage that, what it's caused from.
Shin splints are once again overuse, or actually just a different use. So it's your anterior tibialis muscle, which is right in front of your shin. And shin splints start with what we call hot spots, or I call hot spots. You guys may call them something else. And they're tender points right in the aspect of the shin. We'll see that when athletes start to change cleats up before they start in season specifically, or when they start to break in cleats for season. Once we see symptomology start to pop up, we'll back down very aggressively on that load, whether they're running, sprinting, everything else, until we see that inflammation go down. Because as we all know, I mean, what causes pain is inflammation. It's not the tear itself and everything else. It's the inflammation around it. And once we can get those hot spots to calm down, and we will do some soft tissue of the anterior tibialis. I don't really want to do. I'll do some cold, and if they want to do, we use the game ready as much as we can in a situation like that as well. So we'll take many steps back in order to get them to take a step forward. And then once we start progressing them again, I want to make sure our touches on the field and on the turf and on the running and speed work are very planned out. Like, I want to see 200 touches this week. The next week, I want to see 220, then 240, then 250, and make sure the symptomology stays right behind us instead of ahead of us, so we don't have any reoccurrences whatsoever.
All right, sounds good. What about you, Dr. Patelli? You see a lot with your patients in terms of, you know, runners. I know you used to treat a lot of marathon, you know, NYC Marathon, Boston Marathon. What do you find with those patients?
Absolutely, and it's when they really start to do those big runs is when it comes in, and once again you go to the biomechanics, and that tibialis anterior muscle is just overfiring, and the hot spots would be consistent with a periostitis, or the pulling away of that muscle, which leads to inflammation of the lining of the bone. And I've actually had many runners develop stress fractures of their tibia because they just wanted to run through it instead of taking time off. And you know, that's exactly it. If you decrease the load and start real slow again, they will do well. But the ones that want to keep pushing through it, they're the ones that go on to those tibial stress fractures, which are exquisitely painful.
Right. Yeah, I know. I was experiencing. I did some therapy on myself, and I did some strengthening of the tibialis anterior. You do any tibialis anterior strengthening exercises, Rick, at all with your clients?
Yeah, we do Pilates, which is huge for tibialis anterior. We do a lot of toe-up walking. So, I mean, it's part of our speed progression. I mean, all these athletes do a toe-up walk for 500 yards, so it's just burning like crazy.
Oh, yeah.
Then we'll do a lot of ankling. So it's ankling where you're actually driving off the ball of your foot and then pointing up. So if you can't cock your foot, you can't sprint. Right. So my big thing is I want to make sure that foot is naturally going to be cocked in a situation when we need to sprint and be very comfortable in it. So they're pretty well prepared by the time we get them ready to go in full pattern gauge as far as sprint goes, 100% intensity.
All right. So I know the sprint gait pattern is a little different from the jogging or the long distance. But what kind of gait do you like? Do you like more of a midfoot strike, or like what do you usually try to get your clients to do if they're going to undertake some long distance running?
Well, I'm not a long distance coach, so I'm not
Yeah.
an advocate of anything over 100 yards. So
I agree. Amen.
so you need another resource for that. So that's a different. And jogging and sprinting is completely
two different
different as
legs.
well.
Yeah.
So
definitely.
there's really no heel strike in sprinting at all. You're looking for a strike right underneath the ball of the foot. So if you got the ball of the foot, you're looking for an inch underneath that. That's where you're going to create power from.
Mm-hmm.
And there's a lot of drills that we do to have that athletes create that rhythm with that aspect of the foot and get that feel. And like I said, the best athletes, and you guys all know this, have that ground relationship that are just symbiotic and very, very smooth and very, very just rhythmic. And what I want to do is I want to teach them, because they really haven't been taught 9 out of 10 times, where your strike should be, and then drills to help that strike and how it should sound. Because there's a big aspect of it that you should be, if you're on cement or if you're on a concrete or a driveway, you can do these drills and feel the sound and hear the sound and feel the way it's going to feel at the same time. And then that's where that strike's going to come from. So my guys that were running today, I said do a drop foot, and in front, and almost like we do a falling start, we call it, just it's what we call a weak start to get the athletes used to angles. And the one athlete did a full heel toe strike, and I'm like, no, that you can't create force that way. That force is going to go vertical. I want force that's going to go parallel and vertical at the same time. So teaching an athlete where the foot strike has to be is huge, and then teaching the athlete the drills that help that foot strike is tremendous as far as them getting them to run the way you want them to run.
Right. No, that's great. Now, Dr. Patelli, do you do any recommendations for your patients when they come in, beginning of the year? They're doing they're trying to run that couch to 5K or whatever, and you have any recommendations for them on how to mitigate their pain in their lower extremities?
I'm a big advocate of stretching, and I think a lot of these injuries can be avoided if people stretch properly. And they don't really know how to stretch. Your coaches are not great at stretching. I think your physical therapists like Rick are going to be the ones that really need to work with these guys to get them to be flexible with your Pilates, with your proper form, running or what have you. My God, it brings me back to high school when I used to run high hurdles. I was given 2 Pringles, and I had to keep them in my hands. And if I crushed those Pringles and I was running those hurdles, I had to start over again.
That's actually a great drill. I like that.
Yeah. And I'm a big advocate of for distance and for conditioning of your heel toe gait. Obviously, sprinting is all forefoot. You're not going to get power with a heel toe gait pattern. My main thing is start slow and a lot of stretching. And I believe in cross training. Just because you're going to run a marathon doesn't mean you can't get on that bike. Doesn't mean you can't get in that pool because your endurance is going to build with any of them.
Nice,
and
great point.
Just to build on that real quick, it's like Dr. Patelli said with stretching, is the athletes that come to us first and start with Pilates and they want to go to Pilates, it's hard to make that transition. Trust me, they want to clean on 100 kilos and they want to squat 300 and go. But the ones that start with Pilates and then come to the strength side, their movement's just pure, clean, and beautiful because they're stable athletes, because you want to look for stability, number one, and then they got the mobility, number two. So, and Pilates does that. So we get these movers and all of a sudden you're like, damn, that's impressive. You've never done this before. And they developed that base that allows them to create some more patterning and some more stability when they do it. So it's impressive.
Nice. So, I could probably geek out with you guys for like 2 or 3 hours, but what I'm going to do now is we're going to switch a little bit and kind of finish off. So I'm going to ask both of you some questions, and I want to get your answers, and this has nothing to do with what we just talked about. All right. So the first one is Chicago or New York pizza? Which one is better?
New York.
All right. I thought you were going to say Chicago, Rick, because of where because you spent some time in Chicago. But all right,
I grew up in Chicago, man. That's for the That's for all the visitors. No one eats deep dish pizza who lives there. You eat one of those pizzas, and you don't even like yourself when you're in high school. So
all right. So that's good. That's good. I appreciate that. That New York pizza. All right, Dr. Batelli, which one did you say?
New York pizza, you know that, buddy.
Oh yeah. All right. I wasn't sure. Sometimes those Jersey guys, they act a little weird about New York. You know what I'm saying?
Yeah.
So the next one. What about Godfather or Goodfellas? Which movie was better?
I didn't watch either.
Oh, Rick. Ooh.
I'm sorry.
Really?
I'm gonna have to go Godfather on that one.
All right. So I know Rick has he should have a opinion on this one. Yankees or Red Sox?
You
Watch it. You watch
I mean,
it.
where's this thing gonna be played at? Is this gonna be
you're not gonna answer? You're gonna take the fifth on this one?
Oh, Red Sox all the way. Let's go.
Oh my God, Rick, you're killing me, man. I thought we was cool.
Well, you gotta get some guys pay the bills, man. You gotta take care of the boys.
I hear you. What's your weren't you what's the guy your pitcher that used to work with you or used to
Sale.
Yeah. He's still around? No, not that Sale, the Yankee one. The remember
Hitchcock.
Sterling Hitchcock, yeah.
Sterling is in full retirement mode.
All right, yeah.
He's enjoying life.
I know Batelli. Well, let me just double check. Batelli, Yankees or Red Sox?
Come on, man. I bleed blue. Of course, Yankees.
All right. You better. All right. So now this one is a little more difficult. All right. It's a little more controversial. LeBron or Michael Jordan? Who's the greatest?
We argue about this every day in the weight room. I got 4 strength coaches, and they're going back and forth. My answer is this.
This is a politic answer. It's a politician answer right now.
MJ, Kobe, and then LeBron. And the only reason, like when I was with the Bulls, the reason why these guys are, the fact that LeBron could be so effective being so big, that's what's impressive, right? No, right. You get if you get a 7-footer that could have some sort of athleticism, they're in the NBA back in the day. But LeBron being that big, but MJ and Kobe, I don't think LeBron even has a quarter of their mindset what they have.
All right.
And MJ all the way.
All right, MJ all the way. Batelli?
Gonna have to go with Sir James.
Ooh.
I don't get me wrong. Jordan's probably the greatest player to ever play the game, but he was always surrounded with other great players. You can't knock Scottie Pippen. He was a huge contributor. But LeBron James, no matter where you put him, they all become winners.
But he brings 3 or 4 guys with him wherever he goes. I mean, Cumberbatch, help me out here. What's going on?
See, this is where I'm on the LeBron side, and it's because of longevity and but I agree with the mindset. The mindset definitely is something. And then I don't know. Have you been watching the Last Dance? Did you watching the documentary at all, Rick?
It's funny you ask. I put a post out. I talked to a few of the coaches. I hate to say it, but we lived it. We were there amongst them. I don't want to ruin it. I don't want to see it.
Oh, for real? Wow.
Yeah.
So let me ask you this. I know you've been there. What you got any stories? Any stories of that time? Anything unique that you want to give us a little inside the NBA stuff that nobody knows about? Exclusives here on Ames on Health.
I'm sorry, repeat that.
And some exclusive stuff. Exclusive.
Like what subject? I mean.
Anything with the Bulls. Anything during that time. Anything with the Bulls during that time.
Yeah. Well, Michael, Scotty, and Dennis had a clause in their contract where they didn't have to work out with the strength and conditioning team. So a lot of times they do Scotty and MJ worked out with what's his name, a trainer on the side. I mean, I got tons of stories. I mean, Dennis Rodman was probably my favorite just because we spent the most time together. He'd come in the evenings with his dogs. We'd work out. And, you know, instead of cleaning, snatching, and doing pulls, pushes, and press, Dennis wanted to do biceps, tries, and chest, right? So I would play with the dogs, and I'd join him with the bis and tries. We'd talk about stuff and have conversations just like you and I would. So, I mean, there's nothing different about him whatsoever in that environment. And then you get other players that like make an impact on you. I remember when we drafted Jason Caffey, that was pretty impactful. He was trying to find his role and figuring out what, you know, when you're on a team that has a Michael Jordan and a Scottie Pippen, and you're an all-star in college, and then you're trying to figure out your role. It's very difficult for these guys, and I don't think the general public understands that.
Right.
And it's a young kids with a lot of money, and the money is not their concern. It's really not about that. It's about trying to make a difference and trying to make an impact. And the guys that try to make an impact that are on a team full of all-stars really struggles. And it's a journey for these players. It's not all glamour, and the media never gets anything right. Like, the media is wrong all the time. I can give an interview tomorrow on one of my pitchers or something like that, and they'll get 40% of the information wrong.
Right.
So,
right. So do you have any so that was like just a brief. I just want to get, because we're, being so clinical at times, sometimes they forget that we're, humans, and we kind of, we're normal. We watch TV. Everybody's been affected by the quarantine. So nobody's not been affected by this period of self-isolation, or this period of isolation and social distancing. So I just trying to bring a little levity to the end of this talk or discussion that we're having. So I appreciate both of you coming and joining us on this. It was a good. I learned a lot too. Hopefully the audience will too. And Rick, I want you to give out your any social media stuff that you have. Facebook, Instagram, whatever it is you have. Just let everybody know where you're at and how they can kind of reach out to you, get help.
Yeah, definitely. I'm probably most active on Instagram. It's at Beyond Motion, ATH. That's the best place to reach me. I'm also Twitter, all over social media aspects, and then we're actually have our headquarters here in Naples, Florida. So you could Google that and give us a call, and I'll give you a call back, and we could always talk shop.
All right. And Dr. Batelli, the same thing. Any social media that you want to give out, how they can reach you, contact you, get an appointment, consultation?
Well, obviously the easiest way is through our company website, aimsfl.com, our Facebook page as well, Associates in Medicine and Surgery. Also, you can view my personal website, Batelli.com, DRBATELLI.com, and it'll have some of the different articles that I've written for Train Magazine and some of the other journals in foot and ankle surgery, and some other videos on there as well of some of the surgeries that I do.
Now, once again, I appreciate the time. It was a pleasure discussing this with y'all, and hopefully we could do it again. We can actually get a little more in detail. Once again, this Aims on Health, Dr. Dwayne Cumberbatch. Have a great day.